Welcome to this episode of Season 6 of The Common Bridge, where policy and current events are discussed in a fiercely nonpartisan manner. The host, Richard Helppie, is a philanthropist, entrepreneur, and political analyst who has reached over 5 million listeners, viewers, and readers around the world. With our surging growth in audience and subscriptions, The Common Bridge continues to expand its reach. The show is available on the Substack website and the Substack app. Simply search for The Common Bridge. You can also find us on YouTube and wherever you get your podcasts. The Common Bridge draws guests and audiences from around the political spectrum, and we invite you to become a free or paid subscriber on your favorite medium.
Hello, welcome to The Common Bridge, and we have a returning guest, healthcare expert Nathan Kaufman, all the way from San Diego, Kaufman Strategic Advisors, the preeminent source on all things for healthcare economics. Has been at it a long time. Nate, my friend, it's good to see you. How are you?
I'm doing fine, Rich. Yeah, 48 years in healthcare isn't a long time. It's just it's just a blink of an eye, I guess. So.
Well, that it is. Well, you've seen in those 48 years, healthcare become the largest part of our economy. And I wish this was an original line, but it's been described as the largest segment of the largest economy in the history of the world. And it affects all of our lives. And, look, whenever there's money involved, there are people that do ethical things and then others. And just yesterday, it's been reported that UnitedHealthcare is under criminal investigation for Medicare fraud. What is it that we know about this? What's going on?
Well, there's an organization called MedPAC, which is the Medicare advisory group that advises Congress. And they did a study, and what they found was that they estimate that $84 billion is spent in excess under Medicare Advantage than it would have been under traditional Medicare. In other words, if all those people were in traditional Medicare, the country would have saved $84 billion. So my speculation at this point is where the government is focusing, if they are focusing on something, it would be on fraudulently coding the sickness of Medicare Advantage members.
And that's because under Medicare Advantage, there is a higher reimbursement rate for patients that are more ill. And for those people that aren't familiar with Medicare Advantage, which I term Medicare Disadvantage, there's a gatekeeper, and UnitedHealthcare is one of the biggest gatekeepers. But they offer lower premiums, broader set of services, but you have to go through their approval process. And that's how they get to the lower rate and that reimbursement they get from the government. If there's an adverse selection where they get patients that are more sick, they should get a higher reimbursement. But what you're sniffing right now is that they are coding people that aren't as sick as being more sick.
Yeah, let's go back. Medicare Advantage is basically a private insurance product. So they receive a per member per month payment from the federal government, and then they administer this private insurance to people over 65. Now, the way it works is there's like an average per member per month rate for an average patient. So let's call that $1,000 for a second. But the issue is Medicare recognizes that certain patients are going to need a lot more care than this standard rate. And so each patient is risk scored. So if the standard rate is $1,000 and I have all these chronic conditions and I'm going to need a lot of care, maybe I'll get a risk score of 1.5, which means the commercial insurance company will get $1,500 a month for me, not $1,000. So there's an incentive built into the entire process for the insurance companies to find as many problems with patients as possible and thus get higher reimbursement. And there was a study done recently. They said the average risk score for traditional Medicare was 1.07, while the average risk score for Medicare Advantage is 1.26. In other words, somehow or another, by a miracle or by selection or by upcoding, the patients under Medicare Advantage have more chronic conditions than traditional Medicare.
And potentially they could be lower income people because we've all heard the ads, no premiums, and you get vision and you get dental. They don't tell you the other side of that you also get the gatekeeper. And look, Nate, in our career, we've seen where when the federal government couldn't get the cuts they wanted in healthcare expenditures, they drag out a law. They'd go into a very complex coding world of healthcare and say, you defrauded us. And all right, you can pay us, I know in the case of one of my clients, $40 million, or you can fight it. And our first document request is going to take 3 semi-trucks to haul away. And so they're, that can happen that the government can kind of extort the insurance companies also. We don't know if that's happening, but that's a possibility.
Right. Clearly, I mean, I've been expert witness in a case involving the government, and they kind of have unlimited funding, and that makes it quite difficult. But in this particular case, the evidence is leaning towards the fact that there could be a coding issue with respect to certain plans, and UnitedHealthcare would be one of them. Because UnitedHealthcare, according to this study, out of the $33 million in coding intensity that they identified that was billion dollars, they said they attributed about 14 billion, almost half of that discrepancy, to UnitedHealthcare. So there may be something behind this investigation.
And, UnitedHealthcare is coming out and saying that it's deeply irresponsible, this reporting, that they think it's a stain on their business and their reputation. And their public position is they're just befuddled why this is happening.
Yeah, I mean, that's what one would expect them to say for sure. They also seem to have just lost their CEO. And reinstated a former CEO in their place. So the company is clearly in some state of flux at this point in time. The other thing to point out, that when you look at denial rates, comparing the various health plans, United tends to be towards the top of the list. In a recent study, they had the denial rate for Medicare Advantage, which ranged from about 3.5% to 13.5%. United was at 9%, which means not all claims get scrutinized, but when you're scrutinized in Medicare Advantage, you have about a 1 in 10 chance of that claim being denied. In the commercial side, there's a law in Illinois that required that all denials be reported, and UnitedHealthcare was had about a 20% denial rate, which they themselves reported, meaning 1 in every 5 claims that required prior authorization were actually denied. And one interesting point here is that if you go and appeal these denials, the success rate is like 70 to 80%. So if you're willing to spend the time, it's kind of like the federal government. United has all the time and all the resources. You're a small doctor group or an independent patient. You don't have the resources to go through the entire denial process. So most of the time, these claims that are denied are not appealed.
Yeah, and when you think about that logically, the physician or the hospital, other care setting, they want to get paid. They send claims to United all the time. And it's just implausible that they would say, yeah, we're going to send this to United, but they're going to reject it. They know the game that, United's going to reject it, and then they're going to be delayed and denied and eventually get paid after people who are already sick, by the way, are put through this additional stress. It's a horrible business model, and United's income stream is tax supported.
Yes, most of their profits or much of their profits come from Medicare Advantage. And again, here's a unique statistic. According to Bank of America in 2024, 95% of all Medicare Advantage profits were generated by UnitedHealthcare. So are they doing something better? Are they doing something differently? There was a recent case that involved, this is kind of interesting, a poor anorexic girl, and she was in an institution, and then United decided against her psychiatrist's recommendations that she no longer needed that care and denied the care. And so this went to court, and then it went to a court of appeals. And here's what United said in their own legal documents. They said United contends that reversing its denial would require adopting a, quote, treating physician rule, unquote, which would unduly privilege treating providers over United's paper reviewers. Now, that was in their court documents. And by the way, the one judge in the Court of Appeals said, you are gambling with this little girl's lives. And it's just, what's happened is there's so many conflicts of interest regarding what is best for patients and their physicians versus what is best for the profitability of an organization that, while we can't make any firm allegations, we can certainly see that there's a lot of pressure to get more denials and to do more upcoding and do those kinds of things for an insurance company to generate profits for their shareholders.
And the dilemma I think that we're sitting on here is that there are more pages of Medicare regulations than there are IRS regulations. And so the odds of somebody doing something in conflict with a Medicare regulation is almost a near certainty. And couple that with there's more and more digitization coming into healthcare, not enough and not fast enough, in my opinion. But some of this is resident in systems like Epic, and they're able to look in there. And, I think you've related to me stories about people finding out, oh, they got a diagnosis of congestive heart failure. They go, wait, no, I don't have congestive heart failure, or something like that.
Yeah, there was a case, there's a medical group up in Connecticut called ProHealth. And some of the physicians that retired noted in this article that they felt pressured to put certain diagnoses on the patients. There was training on how to do that. And in addition, they said that when they put these diagnoses, or if they did, then it would appear in the patient's electronic medical record. The patient would be dinged. They'd all of a sudden find out they had vascular disease when nobody told them they did, and they'd have to call the physician up. So you're absolutely correct. There are lots of stories on the web about how providers that are affiliated with insurance companies are also having difficulties. I just want to make one point that you made. It turns out that 24 cents out of the federal budget goes to healthcare right now. And when you look at that, there's absolutely no way to balance the federal budget at this point in time without having some impact on either Medicare or Medicaid. And so what they're doing in Congress right now, everybody needs to watch, because the impact will be significant. Now, if you're not on Medicaid, you say, well, I'm not on Medicaid, it's not a problem. But Medicaid pays 70 cents per dollar of cost. So what happens is Medicaid, and that's what Yeah, and that's what the government is currently looking at, reducing the cost of or reducing coverage for. So if there are less people covered on Medicaid, then they become uninsured. And as a result of that, there'll be significantly more uninsured, and that will put pressure on hospitals and physician groups, and many of them will not be able to be sustainable if they see too many more uninsured patients for which they get no reimbursement.
Yeah, well, that was one of the good things about the expansion, was that at least there would be some revenue coming in, and also people would go see a physician when they had a smaller problem. If you take a person that's uninsured, they're not going to show up until they're in distress. And then you have a very high cost case, and you've just damaged that person's quality of life. And I've looked at the compromise that in the big bill the Republican Congress is leading right now, that their compromise position on Medicaid seems to be they're going to put a moratorium on any new Medicaid provider taxes, that I've explained in a recent column. And there was a part of it that I didn't understand, didn't make any sense to me, that no state could have the Medicaid payment rate higher than Medicare's payment rate. And I thought that was a curious clause. I don't know why they would want to do that.
Well, it's just capping the rates that hospitals and physicians will get paid for Medicaid. That's why they're doing it. Now, Medicare pays about 80 cents per dollar of cost. So a typical hospital, by the way, will have, there's a law called EMTALA, Emergency Medical something. And what it says is, if you're a hospital, you have to treat anybody that walks in the emergency department and provide care to them. And so what's happened in our emergency departments is 40% of the visits are Medicaid because the private physicians can't afford to take those patients. One physician said, if my practice was only Medicaid, I would be on Medicaid. So what happens is all the Medicaid patients and uninsured flood the emergency departments, and they enter the system that way. And that creates huge bottlenecks in the emergency departments and big problems for health systems.
So, again, punctuating the point that there is not a bureaucracy out there, public or private, that is designed to provide any of us more health care. The system is set up to deny us health care, and there are people and companies that are looking at profiting from that. We can't get there by tweaking the current system, in my humble opinion. I don't know that anybody thinks we can. And I think the biggest offender are the big commercial insurance payers, who, remember, they get their revenue from employer groups, for example, and that compensation is not subject to tax on the employee. And that is something that we could bring into balance quite easily. Their business model depends on denying care. And even when there's provisions like the medical reimbursement levels that they need to reach at 80% for small plans, 85% for large plans, they just set up physician groups and they pay themselves from one pocket into another and reap their profits there. And they maybe on a different episode, we should kind of dissect and diagram how the pharmacy benefit managers work. I think you like to call them cartels.
Yeah, 80% of all drugs are funneled through 3 pharmacy benefit managers. One of them's Optum Rx, owned by United. Another one's CVS, owned by Aetna, and another one is Evernorth, which is, or Express Scripts, owned by Cigna. And all these, and I don't want to go into detail today, but we should in a future date, because the issue is healthcare is so complicated that these companies are benefiting from the complexity and opacity of the system. So most people don't understand all the nuances of healthcare, how it works and how people are taking money and where the middlemen are. And so one of the things we can do is spend some time trying to explain that.
Yeah, and you and I have both come together on what our recommendations are for reform. We need more people to get aware and write to their congressional representatives. It is a tragedy that the lobbyists are getting to do this, and we're not being served as a population. And I guess we'll both be watching to see how this investigation plays out with United and see if there's an indictment forthcoming or if it, goes away.
It will be interesting, but it'll also be interesting just to watch UnitedHealthcare. They're the 5th largest company, I think, in the country, if not the world, and they are exceptionally powerful at this point in time. They're continuing to grow, but they are in turmoil at this point in time.
Anything else we need to cover this morning, Nate?
I think we're up to date at this moment. Things could change in healthcare with a vote of Congress, so we'll have to wait and see.
Indeed, and that's almost a sure bet right there. We've been talking today with Nathan Kaufman from Kaufman Strategic Advisors from San Diego, California. A little snippet on healthcare. Expect Nate to be back as a regular contributor to the Common Bridge. And as always, we'd like to get your comments, your questions, topics you'd like to see us cover. And with my good friend and colleague, Nate Kaufman, this is your host, Rich Helppie, signing off on the Common Bridge.
Thanks for joining us on The Common Bridge. Subscribe to The Common Bridge on Substack.com or use their Substack app, where you can find more interviews, columns, videos, and nonpartisan discussions of the day. Just search for The Common Bridge. You can also find The Common Bridge on Mission Control Radio on your Radio Garden app.